In vitamin D fortification, firstly we will see metabolism of vitamin D. Vitamin D has a unique metabolism and is mainly produced in the skin, where exposure to ultraviolet radiation induces the conversion of skin produced 7-dehydrocholesterol into vitamin D3. Dietary intake of vitamin D from natural foods traditionally plays only a minor role with few available natural sources. These may be animal sources such as fatty fish, cod liver oil, or egg yolks contain vitamin D3, and fungal sources such as mushrooms and yeast exposed to sunlight or ultraviolet radiation contain D2. Vitamin D3 and D2 share in general the same metabolism. Therefore, we will not differentiate between these two forms unless otherwise stated and refer to vitamin D, meaning vitamin D3 and or vitamin D2 throughout this manuscript. In terms of sources, vitamin D can also be supplied by supplements and fortified foods, but vitamin D and its metabolites may also be stored and released from the body's adipose tissue. A very rough general estimate is that about 80% of vitamin D supply comes from ultraviolet B induced production in the skin and about 20% from dietary intake. But this varies considerably depending on factors such as season, sun, exposure habits, latitude, nutrition intake, or intensity. Despite a high degree of inheritance of serum 25-hydroxyvitamin D, in twin studies, data from a genome-wide association study indicate that serum 25-hydroxyvitamin D concentrations have only a modest overall heritability due to common genome-wide association study. Single nucleotide polymorphisms of 7.5%, highlighting the great impact of non-genetic factors to the variability in serum 25 concentrations. Vitamin D itself does not exert significant genomic biological effects and has to be metabolized. The common metabolism of vitamin D from any source involves, as a first step, the conversion of 25-hydroxyvitamin in the liver that is mediated by different 25-hydroxylase enzymes. Serum 25-hydroxyvitamin D is the main circulating vitamin D metabolite that is considered to best indicate overall vitamin D status, as it reflects vitamin D supply from diverse sources. Serum 25-hydroxyvitamin D has a traced half-life of approximately 2 to 3 weeks, whereas vitamin D itself has a half-life of only 1 day. In the bloodstream, approximately 85 to 90% of 25-hydroxyvitamin D is bound to vitamin D binding protein, and 10 to 15% is bound to albumin, so that less than 1% of serum 25-hydroxyvitamin D is unbound or free. The classification of vitamin D status is currently based on total serum 25-hydroxyvitamin D concentrations, such as the sum of bound and free fractions of both 25-hydroxyvitamin D2 and 25 hydroxyvitamin D3. It should, however, be acknowledged that there is some discussion regarding whether measuring free 25 hydroxyvitamin D concentrations may also be useful. Such considerations are based on the fact that free 25 hydroxyvitamin D may cross the plasma membrane due to its lipophilic properties, whereas only a few organs that are critical for vitamin D effects such as the kidneys, the parathyroid glands and the placenta are able to take up DBP bound vitamin D metabolites through endocytosis by megalin-cubilin complex. While this is an active scientific debate, it is well established that 25 hydroxyvitamin D per se is hardly biologically active and has to undergo a further hydroxylation step that intakes mainly place in the kidneys. In detail, renal 1-alpha hydroxylase convert 25 hydroxyvitamin D to 1,25-dihydroxyvitamin D, that is also called calcicestrol, are the active vitamin D hormone, whereas the rate of 25 hydroxylation in the liver is mainly substrate dependent until a placent is reached at high serum 25 hydroxyvitamin D concentrations. 1-alpha hydroxylation in the kidneys is under tight control by calcium and phosphate metabolism, including parathyroid hormone, which stimulates 1-alpha hydroxylation, and fibroblast growth factor 23, which inhibits it. Clinical effects of vitamin D. Vitamin D is historically known as. Now we will see clinical effects of vitamin D. Vitamin D is historically known as substance that can prevent and treat nutritional rickets and osteomalacia. Rickets is a bone disease that is associated with low serum calcium and low serum and is characterized by widening and delay of mineralization of growth plates in bones. The clinical presentation of rickets includes heterogeneous skeletal and non-skeletal manifestations such as bowing, deformities of the bones, development delay, or widening of joint. Severe cases of rickets can lead to hypocalcemia, complications including tetany and seizures, as well as dilated cardiomyopathy, which can be fatal. Whereas rickets can only occur in open growth plates, osteomalacia constitute defective mineralization of existing bone, closed growth plates. Rickets and osteomalacia can lead to bone deformation, such as pelvic deformities in girls with risk of obstructed labor, as well as isolated and global bone pain and muscle weakness. Apart from rickets and osteomalacia, vitamin D supplementation may prevent fall and fractures in older individuals at risk of vitamin D deficiency, but data from randomized control trials on this topic are inconsistent. This may be explained by different dosing regimes, with daily dosing may be beneficial and large intermittent bolus dosing may be detrimental. Moreover, it is sometimes difficult to disentangle separate effects of vitamin D and calcium, as there exist interactions between them. Several RCTs with a significant benefit used a combined supplementation of calcium plus vitamin D at doses of 17.5 to 20 microgram. It may be internationally units 7 to 800 per day. Apart from skeletal effects, vitamin D may also have an impact on extraskeletal health. Several epidemiological studies have shown that low serum 25-hydroxy vitamin D concentrations are a risk marker for various diseases as well as mortality. Data from meta-analysis of RCTs suggest that vitamin D supplementation may reduce molarity, respiratory tract infections, asthma exacerbations, and pregnancy complications. But more data are required to clearly establish causality and doses-response relationship. Of particular importance are the RCT data suggesting that vitamin D supplementation during pregnancy may be useful in preventing general complications or infant outcomes such as asthma wheeze. Now look at nutritional vitamin D guidelines. Recommendations relating to dietary vitamin D requirements in general populations are termed dietary reference intake or dietary reference values. These are based on the assumptions that total 25-hydroxy vitamin D serum concentrations are a biomarker of vitamin D status and indicate vitamin D intakes in the absence of cutaneous vitamin D production, which is especially the case in winter at northern latitudes in regions far away from the equator. The rationale for nutritional vitamin D recommendation is the establishment of a cause and effect relationship between vitamin D intake and specified health outcomes. To date, vitamin D guidelines have generally been based on beneficial effect of vitamin D on musculoskeletal health outcomes such as rickets, osteomalacia, fractures, muscle weakness, falls, etc., and occasionally on extraskeletal health outcomes such as pregnancy related health outcomes or mortality. The dose response relationship is then usually characterized by the association between serum 25-hydroxy vitamin D concentrations and these health outcomes. A part of this process, certain target concentrations for serum 25-hydroxy vitamin D are established that are then used to calculate the vitamin D intakes for the estimated average requirement. That is the vitamin D intake at the estimated median requirement, and the recommended dietary allowance, that is the vitamin D intake that meets or exceeds the vitamin D requirements of 97.5% of the population. If the evidence is insufficient to define a RDA, recommended dietary allowance, an adequate intake is defined. The adequate intake is the recommended average daily intake level of a nutrition based on observed or experimentally determined approximation or estimates of intakes that are assumed to be adequate for a group of apparently healthy people. After setting the target, serum 25 hydroxy vitamin D concentrations for the ERRDA and adequate intake. The vitamin D intakes that are required to achieve this concentration threshold under circumstances of minimal to no ultraviolet B induced cutaneous vitamin D production. Vitamin D production are estimated by meta-regression analysis. The DRI also assume that the requirements for other nutrients such as calcium are met. In reality, this is usually not always the case, and vitamin D requirements may therefore even be higher in individuals with inadequate calcium intake and may also vary according to other factors such as body mass index, ethnicity, or genetic polymorphisms related to vitamin D metabolism. A few guidelines recommended relatively high target serum 25 hydroxy vitamin D concentrations such as 75 per mole per liter divided by 2.496 to convert n mole per liter to n gram per milliliter. Because for some musculoskeletal health outcomes and parameters of mineral metabolism such as PTH, these levels may be optimal, whereas target serum 25 hydroxy vitamin D concentrations for effect on the immune system are not clearly established but may be even higher. Now we will see global vitamin D status and vitamin D intakes. Several studies have investigated the prevalence of low serum 25 hydroxy vitamin D concentrations and of inadequate vitamin D intakes in general populations worldwide. It is obvious from these various reports that serum 25 hydroxy vitamin D concentrations and vitamin D supply are insufficient to meet the vitamin D requirements in significant sections of the general population worldwide. There exist, of course, regional differences in the burden of vitamin D deficiency, but it can be clearly stated that vitamin D deficiency is a worldwide public health problem. According to recent surveys, serum 25 hydroxy vitamin D concentrations are less than 30 nmol per liter and less than 50 nmol per liter are documented in 13.0 and 40.4% of the general population in Europe and 6.7 and 26.0% of the general population in the US respectively. Compared to Europe and North America, the prevalence of low serum 25 hydroxy vitamin D concentrations seem to be even higher in many low and lower middle income countries. In India, for example, the prevalence of serum 25 hydroxy vitamin D concentrations below 20 to 30 nmol per liter exceeds 20% in the entire population. It should be noted that interpretation of some previous vitamin D status data may be limited due to problems of laboratory assays, whereas many recent surveys were based on well-standardized 25 hydroxy vitamin D measurement. It should, however, be acknowledged that assessment of vitamin D intakes is not trivial because food composition data are not always up to date with regard to actual vitamin D content of food. Furthermore, 25 hydroxy vitamin D content of food has often not been considered, although this plays a significant role for vitamin D status in consideration of the fact that 25 hydroxy vitamin D is approximately 5 times as effective as an equivalent intake of vitamin D3 in terms of increasing serum 25 hydroxy vitamin D concentrations. Now look at the approaches for the prevention and treatment of vitamin D deficiency. Approaches to improve vitamin D status in the population include increasing intake of naturally vitamin D containing food fortification, vitamin D supplements, increasing solar ultraviolet exposure, and weight loss. Promotion of weight loss, which may mobilize vitamin D and its metabolites from the adipose tissue, as well as increasing intake of naturally vitamin D containing food such as fatty fish, can be considered as general step toward a healthier lifestyle, but such attempts have usually an insufficient overall impact on vitamin D status. Nevertheless, a meta-analysis of RCTs showed that compared to controls, fish consumption, which is usually the highest food source of vitamin D, raised serum 25 hydroxy vitamin D concentration on average by 4.4 nmol per liter. Recommendations regarding more sunlight exposure have the potential to increase serum 25 hydroxy vitamin D concentration, but are limited by adverse effects related to skin damage and skin cancer. Use of vitamin D supplement represent an effective strategy for the prevention and treatment of vitamin D deficiency at the individual level. But adherence within the general population, as well as potential overdosing of vitamin D supplement, are significant limitations. It should also be underlined that supplement intake positively correlates with a healthier lifestyle and higher socio-economic status, suggesting that recommendations for supplement intake do not adequately reach those people at particular high risk of vitamin D deficiency. Therefore, vitamin D food fortification seems to be the most appropriate way of improving vitamin D intake and status in the general population in order to meet dietary vitamin D recommendations. In general, food can be enriched with vitamin D by simply adding vitamin D to food, such as traditional vitamin D food fortification, or by so-called bioaddition. Bioaddition of vitamin D, which has also been called biofortification, refers to various ways of increasing vitamin D content of food without direct exogenous addition of vitamin D. Examples of bioaddition include feeding hens with vitamin D to increase the vitamin D content of the eggs, increasing vitamin D content of feed for farmed fish to increase their flesh vitamin D content. Likewise, with livestock animals in relation to meat and ultraviolet exposure of mushrooms or yeast, that is then used to make bread, which facilitates the conversion of ergosterol to vitamin D2. Now we will see the history of vitamin D food fortification. Even before vitamin D was discovered, it had been observed that cod liver oil protects against rickets. Interestingly, it has been empirically shown that 1 teaspoon of cod liver oil that contains approximately 10 micrograms of vitamin D per day is effective in preventing rickets. Successful treatment of rickets has also been demonstrated by sunlight or UV exposure of children in 1920s, followed by documentation that irradiation of food such as milk increased its anti-rickettsian activity. Vitamin D food fortification has been widely introduced in the 1930s and 1940s in the United States and many other industrialized countries such as Great Britain, when it became possible to add purified vitamin D itself to food. In particular, vitamin D fortified milk was produced at that time, but vitamin D has also been added to a variety of foods and beverages, including amongst others beer, hot dogs, and custard. This food fortification policy was extremely effective in preventing rickets, but in the 1950s there was a change in public health policy. Beyond the combined effect of vitamin D overdosing due to different sources, heavy vitamin D enrichment of dried milk powder plus vitamin D fortified cereals plus daily supplement with 17.5 to 20 microgram of vitamin D. It has also been hypothesized that the hypercalcemia children in Great Britain may have had an inherited disease called Williams syndrome. This syndrome is apart from other pathologies associated with hypercalcemia. Unfortunately, methods for measuring circulating 25-hydroxy vitamin D were not available at that time. However, it has been observed in infants in the German, where infants were supplemented with intermittent doses of 15 microgram of vitamin D as an effort to prevent rickets. In these infants, serum 25-hydroxy vitamin D concentrations increased up to several hundred mole per liter. Current vitamin D food fortification policies. Overviews of current food fortification policies have been reviewed elsewhere. There is a huge variation in availability of vitamin D fortified food or food with vitamin D bioaddition across the countries. In general, there are mandatory and voluntary vitamin D food fortification policies, but their differentiation is not always trivial, as there can be varying pressure and implementation success of voluntary vitamin D food fortification. Many other countries allow voluntary vitamin D food fortification, but with only insufficient effects on vitamin D intakes at population level. Legislation is, of course, the basis for vitamin D food fortification, and while we cannot discuss this issue in detail, in Germany, for example, addition of vitamin D to food is limited to margarine based on a law of 1942. Now we will see cost effectiveness of vitamin D food fortification. When considering introduction of systematic vitamin D food fortification, a key question relates to whether or not such a public health intervention is likely to be cost effective. In general, micronutrient fortification is considered as being one of the most effective public health intervention. Now we will see advantages and disadvantages of food fortification. Firstly, in health, according to World Health Organization mortality data, around 0.8 million deaths can be attributed to iron deficiency each year, and a similar number of vitamin A deficiency and contribute to a significant number of lives lost. A significant body of literature shows that LSFF can have public health impact in higher income countries as well as in low and middle income countries. Fortification programs implemented population worldwide were associated with a 34% reduction in anemia from improved iron stores, with greater benefits realized by those at most risk of deficiency, 74% reduction in the odds of goiter, and a 41% reduction in the odds of NTDs. Now we will see advantage and disadvantages of food fortification in economy. Food fortification is a cost-effective strategy to improve the nutrition status of populations, and it associated with high economic benefits. For example, iodized salt can cost as little as USD 0.05, and wheat and maize fortified with iron and folic acid as little as USD 0.12 annually. The results indicated that for iron deficiency, food fortification was the most cost-effective method, with a cost of USD 66 per disability adjusted life years, whereas supplementation and dietary diversification had estimated cost of USD 179 and 103 per daily respectively. In the case of biofortification, the estimated health benefit to cost ratio was USD 17 of benefits for every USD 1 invested. Despite the enormous economic potential of food fortification, several barriers are not conducive to creating an enabling environment for global food fortification scale-up. These constraints include low private-public partnership and lack of national regulations on food fortification. For example, despite mandatory salt iodization in the Philippines, more than two-thirds of salt is imported and not fortified due to low production capacity. Furthermore, the national production of salt is carried out by producers without a license, thereby avoiding any official controls, and the absence of high-quality laboratories prevent control and monitoring to assess the quality of fortified food. And now we will see advantage and disadvantage of food fortification in social sphere. As outlined in the 1996 Declaration of the World Food Summit, everyone to have access to safe and nutritious food consistent with the right to adequate food and the fundamental right of everyone to be free from hunger. The right to food is also recognized in the 1948 Universal Declaration of Human Rights and is enriched in the 1966 International Covenant on Economic, Social and Cultural. Unfortunately, granting the right to food and nutrition is complex and often overwhelming challenge in many low-middle income countries, particularly in the context of the COVID-19 pandemic, in which mandatory lockdowns and economic slowdowns are leading to increase in food insecurity and malnutrition. Therefore, food fortification can be critical intervention to decrease the risk of malnutrition before, during, and after pandemic. Finally, food fortification, when combined with social safety net programs such as school feeding programs, distribution to the poor, are to vulnerable groups, food for work programs, and food aid during emergency situation, have been effective tools to deliver fortified food to vulnerable people, but also disseminate information on diets. Lastly, we will see conclusions of this review article. In this review, we outlined the background, rationale, and current status of systematic vitamin D food fortification and also gave some guidance for implementation of such an approach. We are of the opinion that the huge gap between the nutritional vitamin D guideline recommendation and the high prevalence of individuals who do not meet their vitamin D requirements calls for public health action that can be performed by systematic vitamin D food fortification. While there are still many questions surrounding this issue, several countries do have long experience with systematic vitamin D food fortification. The successful and well evaluated real life experience with the Finnish food fortification policy may be used as a benchmark for other countries with similar population characteristics. We do hope that our work helped to introduce and modify vitamin D food fortification in those countries where it is needed in order to prevent the significant public health burden of vitamin D deficiency and its adverse consequences. These are the references. From there, this review article have been